Welcome once again to another session of the liver transplantation series on the LGS forum. William Osler said, to see patients without studying books is like sailing the uncharted seas. In a very similar way, without the aid of imaging is equally, if not more, hazardous. Hence, preoperative imaging is vital for the surgeon to be forewarned of the perils and surprises which may lie inside what may no longer be a Pandora's box. Especially in the field of liver transplantation, where the margins for error are so fine, it is imperative for the surgeons to have an in-depth knowledge of radiology, not only the findings, but also why things are done the way they are done. The goal of preoperative imaging is to determine abnormalities that might preclude transplantation, along with abnormalities that will affect the operative procedure, both in the donor and the recipient. As my chief in Stanley, Professor Ravichandran, used to famously say, a surgeon should be able to read a CT scan better than a radiologist. So today, to learn from the best on the fundamentals of diagnostic radiology and its role in preoperative imaging liver transplantation, I welcome our first esteemed speaker, Dr. Srinivas. She is one of the lead consultants in HPV and transplant imaging in Professor Ella's team. Having done her radiology training in India, Dr. Sripriya trained further in the UK, completing her radiology fellowship there. For close to a decade now, she's been an integral member of Prof's team. She is a live wire who is often invited as a speaker at national and international radiological meetings. She is also the course director of the fellowship in HPV and transplant radiology. With numerous research products and projects and publications under her belt, she keeps the surgeons on their toes by picking up findings we might have missed. Now, with so many different anastomoses involved in the operation, especially in an LDLT, the role of intraoperative imaging is absolutely vital. So too in the postoperative period, where imaging may pick up findings and issues and identify them before serious harm occurs to the liver graft or the patients themselves. Hence, radiology has crucial roles to play in these areas as well. And these are skills which every transplant surgeon must know. To teach us these tips and tricks will be our second speaker, Dr. Komalavalli Subbiah. She is a consultant in the radiology unit of Professor Ella's team. Dr. Komala did her radiology training in India, followed by a fellowship in HPV and transplant radiology, winning numerous awards and medals along the way. She's an established member of the team and a highly respected teacher and speaker at meetings. But before that, over to you, Dr. Priya. The floor is yours. If you can share your slides, and you're good to go.
Thank you, Ashwin. First of all, I would like to thank Dr. Patta and Dr. Mohammed Rela for this opportunity to the radiology department. I will be talking about imaging in liver transplant with respect to the pre-operative workup of recipients, both adults and pediatric, and also briefly talk about the donor workup. Komala will be following it up with the intraoperative and post-operative imaging. First slide. What did you press? Okay. So I think me and Komala are feeling a bit like this right now, kind of venturing into the surgeon's territory. So kindly bear with us if we use too much radiological terms. We will try to keep it as general as possible so that it is of use to the surgeons who are there attending this meeting. So overview of my talk would be about the recipient workup. We will briefly discuss the protocol that's followed at our institute, salient features of chronic liver disease and portal hypertension, what we need to report from the surgeon's point of view, and salient features in pediatric transplant. Now, regarding donor workup, it has already been covered extensively by Dr. Rajesh Rajalingam last week. So I'll mainly focus on the segmental anatomy of liver, because it always helps to revise the segmental anatomy from a cross-sectional point of view. And also about, if time permits, I will show some salient normal and variant features that we see in the vascular and biliary anatomy. So the recipient workup, when we do a contrast CT for end-stage liver disease, when we are working them up for transplant, the creatinine that we accept is up to 1.4. Contrast usually given is 100 to 120 ml at a flow rate of 3.5 ml per second. So it's a triphasic CT. Before giving any contrast, we should always do a plain CT. What this triphasic means is it's a late arterial phase followed by a portal venous phase and a hepatic venous phase. 3-minute delayed imaging can be done if required. I will, the timings here are mentioned in what we do in the scanner at our institute. It will vary from machine to machine. So what is more important are these 3 images. So this is a late arterial phase. And this is most crucial for the workup of a liver disease patient. Why? Because not only do you see contrast in the aorta and the hepatic arteries, there should be some faint opacification of the portal veins. Only then, only then, can you stop it? Only then will any hypervascular lesions stand up against the non-enhancing background liver parenchyma. So that is the late arterial phase. Next is the portal venous phase. In the portal venous phase, there should be good opacification of the portal vein and its intrahepatic branches so that we are able to pick up any thrombus within the portal vein, the splenic vein or the SMV. In the portal phase, the liver parenchyma also begins to enhance, as you can see. And last is the hepatic venous phase. The hepatic venous phase should show, as it is in this image, good opacification of all the 3 hepatic veins. They should be filling and draining into the IVC. If you don't see this, just do an immediate run as soon as the hepatic phase is over. It is pertinent to show opacification of the hepatic veins so that you know that it's not a case of Budd-Chiari presenting as CLD. And again, in the hepatic venous phase, we can see the background parenchyma enhancing here. While we are in this slide, we can also look at some of the features of chronic liver disease. So we can see it's a shrunken liver. There will be volume redistribution. So the gallbladder fossa, whatever is to the right of it, is the right lobe of the liver. So as you can see, the right lobe is smaller in size. There is a hypertrophied left lobe. This is segment 4, and this is the left lateral segment. There may be caudate hypertrophy. Other features are the irregular margins of the liver and the heterogeneous parenchymal enhancement. Normally liver should show like the spleen here. It should show a smooth enhancing parenchyma, but with cirrhosis, especially as the cirrhosis continues to progress, it becomes very nodular and heterogeneous. Next, looking for other features of chronic liver disease. So here in this coronal reformatted image, we can see there is moderate amount of ascites. The enlarged caudate lobe is nicely seen here. There will be splenomegaly. Other features of portal hypertension would include varices. So we can see portosystemic collaterals all the way from periesophageal, perigastric. Not everything is seen in this case, I'm just saying. Perisplenic, lenorenal, mesenteric, retroperitoneal, up to perirectal collaterals. Again, with the fluid overload status, you can see some amount of diffuse edematous gallbladder wall thickening, which is normal in a CLD patient. The colon here with this diffuse edematous bowel wall thickening again is normal for a chronic liver disease patient. There may be some haziness of the mesentery as well, which is also a part of the spectrum of chronic liver disease. Now, specifically, what do we need to know from the point of a pre-transplant workup CT? So, portal vein thrombosis. First of all, is there any portal vein thrombus? And what is the extent of the thrombus? And is it a bland or a malignant thrombus? We'll be going through these points. What is a cocoon abdomen? And if there are any prominent portosystemic collaterals, if this is a Budd-Chiari liver, and because it has its own implications, and HCC, if there are any, are they within the transplant criteria? This is Yerdel's grading for portal vein thrombosis, a bland thrombus. So grade 1, as you can see, is where there is an eccentric thrombus which is adherent to the vessel wall, but it is less than 50% of the lumen. In grade 2, it is more than 50% of the lumen of the main portal vein. In grade 3, the thrombus extends up to the proximal superior mesenteric vein, but the rest of the SMV is patent. Grade 4 will be when there is total thrombosis of the SMV as well. Now, this is important for the surgeon because it has its own surgical implications. The surgical techniques that will be employed will depend upon the extent of grading, even if it is a bland portal vein thrombus. Okay. Now, these are two images that show some two images of bland portal vein thrombus. So this is an axial section of a cirrhotic patient. We can see this eccentric filling defect here. So see, the rest of the portal vein is filling nicely. Whereas here, this eccentric filling defect is a bland thrombus in the right main portal vein. So this is the right portal vein, that is the left portal vein. So there's just an eccentric filling defect there. Now, this here is a coronal reformatted image. So we can see the main portal vein there. That's a splenic vein, that's SMV. So this is a Yerdel's grade 1. We can see a thrombus that is adherent to the vessel wall, occupying, say, less than 50% of the lumen. Okay. Now, if there is extensive portal vein thrombosis such that it has resulted in a portal cavernomatous transformation, then that is all the more important because it will lead to a difficult hilar dissection. So here you can see we can't see the main portal vein itself. It's being replaced by what's called the cavernoma, a bunch of venous collaterals at the porta. There will be pericholedocal collaterals, and here you can see pericholecystic collaterals. So if so, this all makes for a difficult transplant and will have to be planned accordingly preoperatively. Next is coming to encapsulating peritonitis, or what is called the cocoon abdomen. So when patients have large volume ascites following repeated paracentesis and repeated SBP, the peritoneum gets inflamed, thickened, and it leads to walling off of the bowel loops. So normally bowel loops should be lying free floating within the abdominal cavity. But here, as you can see, there is a clumping of the bowel loops. This is the same patient. This CT was taken before his transplant. This was taken a few months after his transplant. So you can see that here what we have is a abdominal cocoon, and this is also a case of it will be a difficult transplant intraoperatively. So and this can be easily missed unless we look for this. So what are we looking for? We are looking for features where instead of normal widely dispersed bowel loops, the bowel loops will be all clumped together or loculated rather by the inflamed peritoneum. And treatment for this is nothing. You do the transplant, and once the liver starts working, the layers of peritoneum start de-leaving. So you can see they are all coming apart now. The bowel loops are getting more widely dispersed here. So it will settle by itself once the liver starts working. Of course, another differential for this cocoon is also tuberculosis. One way you can differentiate is by if you tap the ascitic fluid, it may give you a clue. Otherwise, sometimes only intraoperatively, if they see the granulomas, can you know whether the cocoon is actually CLD or tuberculosis related. Okay. Next, coming to extremely large portosystemic collaterals. So this is actually, can you see here, this is a Yerdel's grade 2. So the portal vein is main portal vein is thrombosed, and there are just a few vascular channels there. And all the blood is being diverted through these enlarged splenorenal collaterals into the left renal vein. Now these portosystemic collaterals will need to be ligated intraoperatively. Otherwise, there is a chance of steal phenomenon, and it may lead to graft failure in the postoperative status. Budd-Chiari liver. Now, Budd-Chiari liver has its own, there is a spectrum of findings, all of which cannot be encompassed within this talk. But suffice to say, we need to always look at the hepatic veins in the hepatic venous phase or delayed phase to see whether they are opacifying or not. Now, in this case, so I've taken 2 cuts at the level of the confluence here and here. The veins are not filling, so they are thrombosed actually, and it's been there for a while. So what's happening is there are multiple subcapsular venous collaterals which are actually draining the blood away from the liver. That is why you're getting this mottled pattern of enhancement. And if you go down a bit, you can actually see that these venous collaterals are actually coming out of the liver here and draining into epigastric veins. Could you go back? Okay. So this is another case where actually you're having comma-shaped collaterals. This is a case where the left hepatic vein is patent and the right and middle are thrombosed. So there is a large collateral channel which is draining the middle and right hepatic vein into the left hepatic vein. That is a characteristic comma-shaped collateral. This is a different patient actually. Okay. Now this slide explains how HCC will look in a plain and contrast imaging. I'll follow this with a real CT image as well. So in a plain CT, this is all small HCC that fit within the transplant criteria. So here we see a rounded hypodense lesion on the plain CT. So it's hypodense compared to the adjacent liver parenchyma on the plane. Now, once we give contrast in the late arterial phase, the parenchyma will not have enhanced, but the hypervascular HCC, which is supplied by the hepatic artery, will show nice enhancement. And then you can actually go to the delayed phase where against the background of the enhancing parenchyma, the HCC will show a washout. And if the lesion is large enough to have a discerning capsule, the capsule may show enhancement as well. Okay. Now this is a case where we can see the same. This is, I put an arterial phase, a late arterial phase. So there's contrast in the aorta where we can see against the non-enhancing or the poorly enhancing parenchyma hasn't begun to enhance yet. The hypervascular HCC lights up. And this is the hepatic venous phase where the parenchyma has now begun to enhance, but the lesion HCC has begun to wash out. So this is the typical contrast washout of a small HCC. This is sitting in the superior aspect of segment 8 of liver and well within the transplant criteria. Okay. Now, what happens if you can't give contrast? So many patients may either have hepatorenal syndrome or they may have other associated chronic renal disease because of which we are unable to give contrast. In which case, plain MRI of the abdomen is done in our institute as a good alternative to a contrast CT. While the image resolution may not be as good as what we expect from a contrast CT, it gives us two main features that we need to know. One is the patency of the vessels, is the portosystemic circulation pattern, the venous system, and are there any small HCC that may affect transplant. So here, this is a T2 image, and this is how the liver will look. It has the same irregular margins, shrunken size, volume redistribution. Now, because of the amount of fibrosis in the liver, it will look very hypointense, hypoattenuating or a hypointense we say on MR. So against this hypointense liver, we look for any small, slightly hyperintense areas, which could be a HCC. So if there is a lesion, they will not be very bright. They will be slightly bright. So that is what, there is something here. There is a nodule here. I know it's not very well seen, but which is why we also do another sequence called diffusion weighted imaging, which will bring out this HCC even better. While on this slide, I'll just like to point out, so there is some amount of free fluid. Fluid is bright on T2, so we can see a little bit of ascites, some amount of mild splenomegaly. And next is, this is a diffusion weighted image. So what we look for here, as far as the surgeon needs to know, is there will be three sets of images, what is called the B0, the B500, and the B1000. What we are looking for serially is for any lesion that shows restricted diffusion. Now lesions like HCC, which have a high cellular count, will show restriction of the diffusion of the protons, and that's what the MR machine picks up. So here the ascitic fluid, which is a free flowing fluid, or the cerebrospinal fluid in the spinal canal, they are all lighting up. But as you increase the B value, the CSF has lost its signal, the ascites is gone. So, and instead what lights up is lesions like small HCCs. So you can see this lesion sitting in segment 3 of liver, that is a small HCC. Now, a differential to this appearance can also be in metastasis. They can also light up with the diffusion images. Abscesses also show restricted diffusion, but of course the clinical scenario will tell you what is the lesion that you're looking for. In a setup of CLD, if you're looking for a small HCC and you see something like this, then this can well be an example of a diffusion weighted image helping us in problem solving. quite often, even if we have done a contrast CT and we see a nodule, it is more important, especially when these are sub-centimeter lesions, that it may become difficult to characterize their enhancement patterns. We use diffusion MR always as a problem-solving tool in our institute. I just wanted you to get familiar with this technique. Now, this is another case. This is not one for transplant, but I thought it's nice to show this image. So this is again where a cirrhotic liver, the small right lobe with the hypertrophy left lobe. We can see this slightly hyperintense area. So in T2, the lesions won't be very bright. They will be slightly hyperintense. And you can see the soft tissue, which is also filling up to the right main portal vein. Compare it to the signal void that is there in the left portal vein, which is what we should have normally seen. And then let's go to the diffusion image. So see, the cord is lighting up. So this is a higher B valued image. And we can see the same diffuse infiltrative tumor infiltrating the right main portal vein. So just to highlight the role of MR in looking for HCC or tumor thrombus. Now coming to transplant criteria, I'm sure you're all familiar with this, but let me repeat it nevertheless. Milan criteria says if you have a single lesion, it should be up to 5 centimeters. Whereas UCSF slightly expands it to a single lesion up to 6.5 centimeters. Now, if there are multiple lesions, they can be up to 3 in number, while Milan says that the lesion should not be more than 3 centimeters, a single lesion. UCSF says you can have up to 4.5 centimeter for a single lesion such that the total diameter does not exceed 8 centimeter. Now coming to the Avena criteria. Now the Avena criteria helps us distinguish a bland from a malignant thrombus. So it's quite self-explanatory. So if you have a raised alpha fetoprotein levels, if the tumor thrombus shows expanded, if the portal vein that's thrombosed is expanded, if you can see enhancing soft tissue within it, you can see neovascularity, which is actually like a leash of vessels growing into the portal vein, or if it is adjacent to the site of HCC, then any 3 criteria, if they are present, will suggest a malignant or a tumor thrombus. So this is an image where we can see extensive tumor thrombus in both portal veins. So let's go through this image. This is a late arterial phase, as contrast in the aorta, and this is a hepatic venous phase. So in the late arterial phase, here we can see the parenchyma really hasn't enhanced, but look at the portal veins. There should be just a faint opacification normally. Instead, we are seeing some soft tissue that is filling the portal veins. This is the right portal vein, this is the left portal vein. It's drawing the vessels also along with it. And even if we are not really seeing the enhancement, see in the hepatic phase, the lesion has washed out. So the soft tissue that has infiltrated the portal vein is showing washout just like the primary tumor. So there's probably a primary tumor that is sitting here, which is infiltrated the right main portal vein as well as the left portal vein. We can even see a part of the left portal vein that is still opacified here. So this is a HCC with a tumor thrombus, which is fitting the Avena criteria. Again, coming to the grading of the portal vein thrombus. So this is a Japan's VP classification. So what it says is, if you have a tumor sitting here, say this is segment 8 of liver, and this infiltrates, if the tumor thrombus infiltrates the segmental branch, say segment 8 branch, that comes under VP1. Now, if it further goes into the right anterior portal vein, that is called VP2. In our center, VP1 are taken up for transplant, whereas for VP2, we usually pre-treat the patient with either TACE or SBRT or TARE and downstage the tumor before taking them up for transplant. VP3 is if the tumor thrombus extends into the right main portal vein, and VP4 is if it either extends into the main portal vein or the contralateral left portal vein. And usually in our center, VP3 and VP4 are not taken up for transplant. This may change from institute to institute. Another important indication for LDLTs is acute liver failure setting. So in the setting of acute liver failure, we are not going to see the spectrum of findings that we saw in a chronic liver disease that I had been showing till now. What we would see at the most is an enlarged and steatotic liver. So this here is a plain CT and this is the contrast CT. So both of which are showing fatty changes in the liver. The liver is enlarged and fatty. And we may see signs of liver dysfunction like ascites. We can see here there's some free fluid around the liver. You can see pleural effusions and fluid in the pelvis. With this, I would like to stop with the adult recipient and go to the pediatric pre-transplant liver workup. Now, common indications for this are usually biliary atresia, hepatoblastoma, and metabolic liver diseases. Especially in biliary atresia, because it's a congenital anomaly, we need to look for a lot of other factors as well. So we need to see what is the size of the portal vein, how is the IVC, is it patent? And especially the syndromic variant of biliary atresia, there may be other associated anomalies like malrotation, situs inversus, heterotaxy, or pre-duodenal portal vein. So it will help to be aware that these things can occur, and unless we look for it, we will miss it. Hepatoblastoma, I'll be briefly talking about the COPL pre-treatment and post-treatment extent staging of tumor to decide further management. Biliary atresia. So biliary atresia, usually this is how the liver will look. Both lobes will be enlarged. So you can see the cirrhotic heterogeneously enhancing parenchyma here, and the irregular margins. There may be other features of portal hypertension, splenomegaly, varices. And what is classic is these layers, these areas of tubular or even saccular fluid-filled areas, which are the bile lakes or dilated peribiliary glands. So when we see biliary atresia, we have to look at the size of the portal vein. Now in the image on the right here, that's a hepatic artery and that's a portal vein. So the portal vein here measures, the measurement here is 5 millimeters. As long as it is over 4 millimeters, usually the surgeons may not take it for a portal vein reconstruction. But if you see the image here, the portal vein is hardly 2 millimeters in size. So this will be one for which they will need to do a portal vein interposition graft. Also, just you can see the extremely dilated bile lakes here, or the biliary glands. So there is a spectrum. They can range in their appearances. Gallbladder will never be seen in a case of biliary atresia. Another thing to remember is these patients may be in a post-Kasai status. So the portoenterostomy may be also visualized at the hilum. This is called BASM, the biliary atresia splenic malformation. So here the associations are commonly polysplenia. So we can see here multiple enlarged spleens. This is a part of the heterotaxy syndrome. Here, this is a case of annular pancreas. So what we see is actually just like the normal pancreas, you will see enhancing pancreatic parenchyma, but they will be to the right of the second part of duodenum. So this is the second part of duodenum. And you're seeing, this is how it will look on the axial section. So we have to look for this. If this is not a node, and if this is in continuity with the rest of the pancreatic parenchyma on the coronal plane, then this is a case of annular pancreas. Another thing to look for is malrotation. It's not seen in this, but what we would look for is the second part of duodenum as it comes and becomes a third. The third part should nicely cross the midline such that the duodenojejunal flexure is always to the left of the midline. And we have to look for it in every case of, especially in infants, when we see the infant CT, we have to make sure that there is no malrotation. Other things to look for, as I said, maybe situs, preduodenal portal vein, other associated anomalies in other organs, there may be hydronephrosis, etc. So we have to scan each and every organ to make sure there are no other associated congenital anomalies. This specifically applies to biliary atresia. Okay, coming to hepatoblastoma. Hepatoblastoma, this is a COPL staging for pre-treatment and post-treatment extent of tumor. So they have divided the liver into 4 sections, they say. So let me just briefly describe what this section is, and then we can just read up the staging. So this section here on the rightmost is the right posterior segment, which is both segments 7 and 6. The section here is the right anterior section, which is segments 8 and 5. This section here is the segment 4, and this is the left lateral segment, which is segment 2 and 3. Now, according to the pretext staging 1, if one section is involved such that 3 adjoining sections are free, it is pretext 1. In pretext 2, 1 or 2 sections of the tumor are involved such that 2 adjoining sections are free. In pretext 3, 2 or 3 sections are involved such that no 2 adjoining sections are free. So they have very nicely described it. So we can see here no two adjoining sections are free. Pretext 4 is if all 4 sections are involved. Now, after the chemotherapy, if in the post-treatment staging, it is a pretext 4, it's a definite indication for liver transplantation. Whereas for the others, we can try resection also. This is an image showing a good response to chemotherapy in a case of hepatoblastoma. So the pre-treatment shows a large heterogeneously enhancing mass with central necrosis. It's occupying almost the entire right lobe and even part of the segment 4. And we can see here in the post-treatment how the tumor has nicely shrunken in size and the rest of the background parenchyma has regenerated. Okay, coming to the donor workup, since it was quite extensively discussed in the last talk by Dr. Rajesh Rajalingam, I shall briefly talk about the segmental anatomy and how we calculate the volumetry. So this is the Couvenard's segmental anatomy with the hepatic veins between the segments, which we are all familiar with. But let's look at it in an axial cross-section. So this is an axial cross-section because this is how we will see it on CT or MR. So this is one section that is taken at the above the porta, above the level of the porta. So we have to imagine this is a hepatic venous phase and we can see the veins filling up. If this is the right hepatic vein, the liver behind it becomes the segment 7. The part of liver between the right and the middle hepatic vein is segment 8. The part that is medial to the middle hepatic vein and limited by the fissure for ligamentum teres is segment 4A, and medial to that is segment 2. Now we go to a section below the porta there. So what was segment 7 becomes 6, and we can see the level of kidneys here, so we have come down. What was segment 8 becomes 5. What was 4A becomes 4B, and what was 2 above becomes 3. Our gallbladder will also be lying somewhere here below. Okay. Donor workup, CT protocol is almost similar. We give 100 to 120 ml contrast at a faster flow rate. The only difference is that we do a proper arterial phase or an early arterial phase. So in a donor, we do not want any portal vein contamination at all. We want to see the arteries and we want to see them properly. We want to look for any aberrant anatomy. And to be able to do any of this, we should see the arteries and only the arteries. Sometimes arteries can be, they are not hypertrophic like in the recipient, so they may be very thin. We may want to look at the segment 4 arteries. So to do all this, we should do a proper arterial phase. It's an angiogram actually. The portal phase is the same as in the recipient CT and then the hepatic venous phase. We do the volumes calculation in the hepatic venous phase. The only thing I would like to mention here is that donors should be well hydrated. Only if they're having a good hydration status will the veins be well expanded and we can measure the diameter of the veins. We can map out their tributaries and drainage patterns. If required, if the hepatic veins are not well opacified, we can do a delayed imaging, but it's not always essential. So this again, Dr. Rajesh had nicely covered last time about the liver attenuation index, the LAI. What is this LAI? It is nothing but the difference between the average attenuation of the liver and the spleen. So this is a patient who has a good LAI. His LAI was 11 actually. So we can see that the liver is quite hyperattenuating and compared to the spleen. The average the liver values are around 63 and 60, while the spleen is around 48. Whereas here, this is a very steatotic liver. So we can see when you compare to this, the liver fat actually has a very low attenuation. So when there is diffuse fatty infiltration of the liver, it brings down the liver attenuation. So what was 63 in the other slide is now 9. That's the liver attenuation. So his LAI was actually minus 35 in this patient. And one thing to think is when you look at a CT like this, where no contrast has been given, there is no contrast in the aorta or the portal vein, but still the vessels look bright just because of the pure density of blood against the fatty infiltrated liver. If the plain CT itself begins to look like a contrast CT, then you know that there is significant fatty infiltration in the liver. The only thing I would like to point out is if LAI is over 5, it's good, you can proceed with donation. If it is less than 5, usually not acceptable. If it is in between, then it depends on the donor surgeon, whether it depends on the patient's age, his BMI, his liver function tests, and the donor surgeon may take a call as to whether he wants to motivate the patient, the donor, to lose weight and then repeat the LAI. One thing I would like to talk about is how we calculate the volumetry. So what we do, every cut of the liver from the superior to the inferior most extent, we map out the liver margins, but we leave out the IVC and the portal vein, and then feed it into the computer software, and it will give us the whole liver volume. We do the same thing for the right lobe as well. In our institute, the way we cut is the medial border is along the right border of the middle hepatic vein. So this is the right lobe without the MHV. So we follow the MHV superiorly, and inferiorly we come up to the gallbladder fossa. That is the right lobe volume. Once we subtract the two, we can get the left lobe volume. So the remnant liver in the donor, as you all know, must be at least 30%. And the graft weight that we take with the recipient weight ratio must be at least 0.8. Left lateral segment, this is done in a pediatric setup. So we cut along the fissure for ligamentum and along the margins of segment 2 and 3. In this case, it is 252 cc. And sometimes this itself may be too much for a small infant, and they may need to even cut this down on table. Is that time, Ashwin, that can I just show a few salient arterial variants?
Yes, Dr. Priya, go for it.
Thank you. So just a couple of more slides left. So this is just revising our hepatic artery anatomy. The common hepatic artery takes off from the celiac axis. It gives a gastroduodenal artery and the proper hepatic artery, which then gives the right and left hepatic arteries. So these are reformatted images. The cystic artery usually comes off the RHA. The segment 4 artery is coming off the LHA. Now this is a commonly seen variant where the replaced right hepatic artery is coming from the SMA. So in this case, the common hepatic artery directly gives off the left hepatic artery. Now portal vein, again this is a reformatted image. So we can see here the main portal vein, which divides into the left portal vein and the right main portal vein, which will give the right anterior and the right posterior portal vein. Now here is a variant anatomy where the right posterior portal vein is the first branch of the main portal vein. And then there is a short trunk that bifurcates into the right anterior and the left portal vein. This is called Nakamura type C anatomy. Hepatic veins. So as I said earlier, we need to ensure good hydration status of the patient so that the veins don't collapse, and we are able to measure the diameter of the right, middle, and left hepatic veins. So this is a section taken at the level of the confluence, and the surgeons see the map the tributaries of the drainage patterns of all the three veins. Every donor liver changes, so each liver is different from another. So it's important to get the anatomy right. If there are any accessory hepatic veins, anything more than 2 millimeters, which is draining away from the confluence, we need to mention them. So here we can see a IRHV, an inferior right hepatic vein that is draining below the confluence, and it's of a significant size. Anything more than 2 millimeters, we measure in the report, mention in the report, so that if they need to be reconstructed in case of a right lobe graft. This is my last slide. This is talking about biliary anatomy. So the normal anatomy we should be familiar with, and biliary anatomy we described from above. So that is the right anterior duct and the right posterior duct forming the right hepatic duct, which will join the left hepatic duct to form the common hepatic duct. Once it receives a cystic duct, it becomes a common bile duct. This is a commonly seen variant anatomy where the right posterior duct will join the left hepatic duct just above the confluence. Then they join the right anterior to form the common hepatic duct. Once they receive the cystic duct, it becomes a common bile duct. I think at this point, I shall end my talk. The patient is now in theater, and Dr. Komalavalli will take over.
Thank you very much, Dr. Priya. It was a very comprehensive talk with regards to the adult, pediatric, and ALF recipients, and with regards to donor CT imaging. What I enjoyed about your talk was it was completely surgeon-centric. I mean, it was how a surgeon would want to look at imaging. If we can have Dr. Komala finish a presentation, and then we can maybe take questions together.
Thank you, Ashwin.
Dr. Komala, if you can switch on your camera and then start slide sharing, please.
Thanks, Dr. Ashwin, for your kind introduction and for the invitation. I'll discuss about the intraoperative and postoperative liver transplant imaging. Just a minute. So basically, the liver transplant reconstruction contains two inflow reconstruction, that is the hepatic artery and the portal flow, and outflow reconstruction, hepatic vein, and the biliary reconstruction. This is a whole liver graft, which is usually done in DDLT. Here, the vascular anastomosis is done more proximally, and this is an partial lobe graft, that is a right lobe graft in adult, and this is the left lobe graft, left lateral segment graft, which is usually done in pediatrics. Here, the anastomosis is more towards the liver, that is towards the hilum. This is very important because always in LDLT, we have to image the vessels more towards the liver. That is, the intrahepatic segments has to be imaged. And Doppler ultrasound is the primary modality which we use in the intraoperative as well as the postoperative period. If the Doppler findings are indeterminate or there is a persistent clinical suspicion of an abnormality, then we proceed with the contrast enhanced CT scan, usually triple phase CT with the early arterial phases done. CT is also sometimes done to confirm the Doppler findings as well as to find out any intra-abdominal collection is there or a focal collection is there. And also sometimes it is done for the parenchymal abnormalities. The role of MRI in the immediate postoperative period is very minimal. However, for delayed biliary and vascular complications, we use MRI. We do MRCP, MI-angio, or MR venogram depending upon the clinical need. The role of nuclear imaging is very important in the setting of an appalt, which I will discuss in the coming slides. And whenever intervention is needed, intervention radiology comes into play. So since Doppler is the primary modality in the immediate intraoperative as well as the postoperative period, we should know some basics about the Doppler. So the Doppler ultrasound usually starts with a grayscale imaging, which we say as the B mode imaging. The presence of an anechoic lumen usually ensures the patency of the vessel. However, acute thrombus will also be anechoic. So we have to ensure that flow is present within the lumen. Color Doppler tells us whether flow is present or it is absent, and it overlays the color over the grayscale image. The red color, whenever the flow is towards the transducer, red color will be seen, and whenever the flow is away from the transducer, blue color will be seen. And this is a spectral Doppler, which gives us the waveform. So spectral Doppler, in order to get a good waveform, we need to follow certain things in spectral Doppler. Spectral Doppler, it involves the manual placement of a sample gate. The sample gate should be at least 2/3 of the luminal diameter, and it should be placed within the center of the vessel lumen. And the Doppler angle, that is the angle between the ultrasound beam as well as the direction of the blood flow, should be less than 60 degrees. If it is more than 60 degrees, then erroneously high velocity will be recorded, and we have to adjust the scale according to the velocity. And sterile coupling gel should be used whenever we do the Doppler. In intraoperative Doppler, we don't use a coupling gel. Instead, warm saline is adequate to perform the Doppler. And this is the machine what we use in our unit, Logic P9. And this knob indicates the B mode, and this is for color Doppler, and this is the spectral Doppler. And there is a thing called PD. It is the pulsed Doppler. This is mainly used whenever there is a slow flow, because rather than the Doppler shift, it picks up the amplitude. And the transducers what we use are these two types. One, this is the curvilinear low frequency transducer, which is mainly used in the postoperative period, postoperative Doppler. This is because low frequency transducers allow for an increased depth of penetration, whereas the linear high frequency transducer is used in the intraoperative Doppler because we are placing the transducer directly over the surface of the liver and we don't need an increased depth of penetration. So in order to, whenever we need to pick up an abnormal waveform, it is essential to know the signature waveform of the hepatic vessels. And this is the signature waveform of the hepatic artery. Basically, when the flow is towards the transducer, it is represented above the baseline. As in case of hepatic artery and portal vein, when the flow is away from the transducer, it is represented below the baseline, as in case of a hepatic vein. So the hepatic artery waveform is an antegrade waveform, and it is pulsatile and it is monophasic, and the peak systolic velocity is usually 70 plus or minus 80 centimeter per second. And what is more important in the hepatic arterial waveform is that the RA is nothing but the resistive index. It is a quantitative measurement of the impedance to the flow. And how we measure the RA is that we have to take the peak systolic velocity and the end diastolic velocity. And using this formula, that is peak systolic velocity minus end diastolic velocity divided by peak systolic velocity gives the RA. Normally, hepatic artery is a low resistance vessel because the flow has to be maintained throughout the cardiac cycle. And the normal RA of the hepatic artery is 0.55 to 0.70. And portal vein is usually monophasic and the direction is towards the liver. It is seen as a red color. And the normal diameter of the portal vein is 12 to 13 mm with a normal velocity ranging between 15 to 30 centimeter per second. And this is the signature waveform of the hepatic vein. The hepatic vein is usually blue in color because the flow is away from the transducer. And this is the triphasic, classical triphasic pattern of the hepatic vein. And mainly it is below the baseline, and a small wave, that is the A wave, is above the baseline. This is a retrograde wave, and this wave is because of the atrial systole, and during this the blood flow is away from the heart, that is towards the liver. And this picture says the various phases of the cardiac cycle and how the right atrial pressure is transmitted in the hepatic waveform. And whenever we are not able to see this triphasic waveform and there is a complete loss of phasic variation, that is a non-phasic, this is called a monophasic waveform with loss of phasicity. This is a worrying picture as far as hepatic vein is considered. And Doppler is the principal imaging in intraoperative and postoperative period because it is non-invasive, repeatable, and it allows a real-time imaging and gives us idea about the patency of the vascular anastomosis, but it is observer dependent. And intraop Doppler usually helps to identify the vascular complications at the earliest so that the intervention can be, so that it can be intervened at the earliest possible. And whenever we are asked to do an intraop Doppler, first we need to review the preoperative imaging of both the donor and the recipient to know any variant anatomical, to know any variant vascular anatomy. And the surgical technique has to be discussed with the surgeons regarding the anastomosis. And usually it is performed before the biliary anastomosis. We have to follow the sterile precautions and we have to maintain a convenient position that is usually to the right side of the patient. After sometimes the scanning can be delayed so that adequate time is given for the hepatic artery to recover from the spasticity. And with this knowledge about the surgical procedure, we should proceed to do the Doppler. Usually a whole liver graft in case of DDLT or a partial lobe graft, and sometimes support is usually being done. When coming to the anastomosis, the portal vein, hepatic artery and the bile duct, usually end-to-end anastomosis is done. Hepatic veins, it can be end-to-end or it is a picky-pack anastomosis, and gallbladder is usually removed. And sometimes B5, B8 reconstruction is needed. It is reconstructed with the help of a PTFE or a preserved cadaveric iliac veins. And in case of biliary atresia and the pediatrics, usually there will be hypoplastic portal vein. And in that scenario, and whenever there is a previous history of portal vein thrombosis, sometimes interposition graft or a jump graft is placed. And portal flow modulation techniques such as collateral ligation, splenic artery ligation and portocaval shunt is also performed. This is how we do the intraoperative Doppler. This is left lateral graft, and here the hepatic artery anastomosis is being done. The portal vein and the hepatic vein anastomosis is already over. So after the hepatic artery anastomosis and before the biliary anastomosis, we start doing the Doppler. Here the transducer has to be kept directly over the liver surface, and it has to be gently pressed, and it has to be angled cranially. So from cranial to caudal, we should make a sweep. Cranially, we can see the hepatic vein. The hepatic vein should be blue in color, and we should get a triphasic pattern, classical triphasic pattern of the hepatic vein. And whenever there is a V5, V8 reconstruction is done, we should also image V5, V8 and the IRHV. And this is how we image the portal vein at the Rex recess. The portal vein has to be imaged. First, the grayscale image of the entire length of the portal vein should be made for the presence of any thrombus. And then we should look for the velocity of the portal vein, which is usually between 50 to 80 centimeter per second. And imaging of the hepatic artery, always the hepatic artery should be imaged in the intrahepatic portion. And this is a classical waveform of the hepatic artery. We should measure the peak systolic velocity and the end diastolic velocity, which gives us the resistive index. The resistive index is usually high in the immediate postoperative period as well as intraoperatively because of so many reasons. I'll tell it in the future slides. And this is a right lobe graft. So they are making the picky-pack, and this shows the picky-pack anastomosis of the hepatic vein. And this is the right portal vein is anastomosed to the main portal vein. And this is the PTFE anastomosis, V5, V8 reconstruction using the, it's a donor, harvested donor iliac vein. And this is the right hepatic vein. We can see the blue color, and sometimes an orange reflects at the site of anastomosis itself says that it is patent. And the portal vein is imaged at the level of the hilum, and we are recording the portal vein velocity. And the hepatic artery, intrahepatic segment of the hepatic artery is imaged, and we get the classical picture with an RI of around 0.8. And this is how we perform the intraoperative Doppler. And coming to the postoperative imaging, even in the postoperative imaging, the primary modality is the Doppler ultrasound. And this is the algorithm which we follow. So first we do the Doppler ultrasound. If it is normal, unless until clinically indicated, no other investigation is performed. And if it is abnormal or the Doppler findings are indeterminate, we have to proceed with the other modalities. When we suspect any parenchymal abnormality, we proceed with CT. And to confirm the vascular abnormality, we usually do CT angio. And if it is abnormal, then we proceed with the intervention. And for biliary complications, usually MRCP is the diagnostic modality of choice. And intervention is done with ERCP. And postoperative Doppler, usually in our unit, the person who is doing the intraoperative Doppler will also do the first extubation postoperative Doppler. If it is not possible, and if the person is going to do the extubation Doppler for the first time, it is very essential to have a review of the intraoperative notes. We have a white card which tells us the details about the surgical anastomosis and the major events that happened in the surgery related to the imaging. After having that knowledge, we have to perform the postoperative Doppler. Postoperative Doppler is a bit difficult because of the technical limitations. We cannot expect a perfect positioning from the patient, and also a lot of surgical bandage will give us only a limited window to do the Doppler, and the body habitus also decides the quality of the imaging. And we have to follow the sterile precautions. We have to use the sterile gel, and the frequency, how frequent the Doppler is done in the postoperative period. No RCT investigates the optimal frequency. Each center decides its own policy. In our unit, the first examination is done before extubation, that is less than 2 hours, 12 hours. Then consecutively every day, it has to be done for 5 days in adult. And in case of pediatric transplant, a BD Doppler is done for the 5 days. This is because the caliber of the pediatric vessels is very thin, and also the complications expected is a bit high in pediatrics. Additional examination depends upon the clinical need and just before the discharge. In case of donors, the first Doppler is done 24 hours after the donation and then on the 6th PO, just before the discharge. So we should have a set, everyone should have their own protocol while doing the postoperative Doppler. So first the vascular anastomosis is evaluated, starting from the hepatic vein, then the portal vein, and then the hepatic artery. So whenever the hepatic vein is blue in color and we get a classical triphasic waveform, then we are happy. When there is a variation in this, that is, when we get a red colored hepatic vein or this kind of imaging, that is a monophasic with complete loss of phasic variations, then it needs to be evaluated. Mostly in the immediate postoperative period, it is mainly because of hepatic venous outflow obstruction. It could be because of a focal hepatic vein thrombus or an extrinsic compression by a clot, or because of anastomotic edema, or because of a kinking. In case of donor, graft rotation causes a kinking and it gives a monophasic waveform in the hepatic veins, and also altered cardiac status can give this sort of a monophasic waveform. So this is a case of a focal echogenic thrombus at the confluence of the right hepatic vein, that is at the level of anastomosis. Here we can see a dampened monophasic flow, and the hepatic vein is red in color because of the retrograde flow. And if you see the similar imaging, that is a dampened flow, monophasic waveform with the loss of phasic variation, in the delayed follow-up imaging, then we have to suspect a hepatic vein stenosis. So in the grayscale, we can see a beak sign or a waist sign. And what is very important is that rather than the dampened monophasic flow, what is very important is that a threefold increase in the anastomotic jet velocity when compared to that of the pre-anastomotic velocity. And usually the velocity will be less than 8 to 10 centimeters with the loss of phasic variations. In this scenario, we have to proceed with the conventional venogram to know the pressure gradient across the stenotic segments of the hepatic vein. If it is more than 7 mm, then need to be intervened with either stent placement or angioplasty.
It's 21 hours.
And this is a case of suprahepatic IVC narrowing, in which case the IVC, intrahepatic IVC shows a red color retrograde flow with the dampened monophasic flow. And with this, we come to the portal vein evaluation. The portal vein is usually evaluated at the level of the hilum. In the grayscale, we have to look for the patency of the vessel. We have to look for any echogenic debris inside the lumen or attached adherent to the wall of the lumen. We have to see the entire length of the portal vein down to the confluence of the splenic and the superior mesenteric vein to detect the thrombus. And this is a case where we saw an echogenic debris in the portal vein. This is a left lateral graft at the level of the rex. And on the color flow, that there is no color flow in the intervening segment, which is confirmed in the CT. So there is a non-opacification of a segment of the portal vein. And this is a case of a portal vein thrombus, acute portal vein thrombus. So after confirming the patency of the portal vein, we have to evaluate the flow variations. Normally, we don't see the flow, we use only the velocity. Flow is nothing but velocity multiplied by the luminal diameter. Usually, there is a bit high velocity in the portal vein in the immediate postoperative period. Usually, it is around 50 to 80, sometimes 90. This is because of the persistent hyperdynamic circulation in case of cirrhosis with portal hypertension. And one another cause is that the entire recipient's portal flow has to go into the partial liver. So normally there will be an increased portal velocity in the immediate postoperative period. But when the velocity is more than 125 centimeter, we have to know about the graft recipient weight ratio. When there is a suboptimal graft recipient weight ratio, that is a relatively small graft, then we have to think of the hyperperfusion syndrome or small for size syndrome. In this scenario, the surgeons will take up the call after measuring the portal pressure. Similarly, when the velocity is very low, that is less than 10 to 15 centimeters, which happens usually in the pediatric transplant. This is because in biliary atresia, the portal vein will be hypoplastic. And in adult, it happens in case of history of pre-operative portal vein thrombosis and an extensive portosystemic, a large portosystemic collateral, or sometimes when portal flow modulation technique like portocaval shunt has been done intraoperatively, this scenario can happen. In this case, we have to find out the reason and we have to intervene accordingly. For example, either they do a collateral ligation. In case of portocaval shunt, they do a shunt occlusion. And this is a normal picture, what we see in the postoperative period in the portal vein. That is an anatomic caliber mismatch. Caliber mismatch is a normalcy in case of portal vein. This is because the small right portal vein is anastomosed to a large main portal vein in case of a right lobe graft. And in the left lobe graft, the large donor portal vein is anastomosed to a relatively small caliber recipient vein. So this anastomotic, this caliber mismatch is a normacy, but we need to differentiate this anastomotic caliber change from the stenosis. Usually a threefold elevation in the anastomotic velocity in compared to that of the pre-anastomotic velocity, and also with the mild post-stenotic dilation, as we see here, is favors the stenosis. An intervention is sorted when the anastomotic caliber is less than 5 mm, when the stenotic ratio is more than 50%. So, and one another thing we need to know is a helical portal flow. This is also common in the post-transplant setting. This helical blood flow is because of the turbulence, because the flow here is not laminar and it is a spiral flow. We can see both red and the blue, and in the waveform we can see the wave both above the baseline and below the baseline. Sometimes erroneously we consider this flow to be a hepatofugal flow, but looking at the intrahepatic segments of the portal vein, we can exclude the hepatofugal flow if it is red. So when a portocaval shunt is done, we have to see the shunt, we have to comment about the shunt patency, and usually the flow is away from the liver, that is blue in color, and we have to record the shunt velocity along with the portal vein velocity. And coming to the hepatic artery evaluation, always the post-anastomotic segment of the hepatic artery, that is the intrahepatic portion, has to be evaluated in case of an LDLT. And if we use a linear probe in the intraoperative period, because of a better resolution, we can even view the anastomotic site as two echogenic dots on the wall. And usually the hepatic artery resistance is a bit high in the immediate postoperative period. What is worrying in hepatic artery waveform is whenever we are not able to record the waveform, which indicates that there is no flow in the hepatic artery, or when the intra-segment hepatic artery RA is very low, both these conditions need immediate intervention. So what I mean by low, whenever there is no flow in the hepatic artery, first we have to adjust the Doppler settings, and we have to try using the pulsed Doppler, because pulsed Doppler picks up the slow flow in a better way. Even after adjusting the Doppler settings in the use of pulsed Doppler, we are not able to get the waveform. Then we have to proceed with the CT angio to confirm the diagnosis of hepatic artery thrombosis. So whenever we see a low RA in the intrahepatic segment of the hepatic vein, hepatic artery, low RA, what I mean by low RA is the resistive index is less than 0.5, and the waveform looks like this. This is called a Power status pattern. That is, the peak systolic velocity is much lower, and there is a slow rising systolic peak. Because of this, the acceleration time is increased. Normally it is less than 80 milliseconds. In this scenario, it becomes more than 80 milliseconds. If we get this sort of waveform under low RA, we have to screen the entire hepatic artery to know the hemodynamics. we have to search for any focal increase in the peak systolic velocity or a focal color aliasing. If there is a focal increase in the peak systolic velocity more than 200 centimeter per second, then it is mainly because of a focal caliber narrowing. This can be caused because of an extrinsic compression by a significant clot or an anastomotic edema or some sort of kinking. And in this case, the portion of the hepatic artery proximal to it will have a high RA and will have a high RA. If we are not able to find any focal increase in the hepatic peak systolic velocity, and if in the entire hepatic artery there is a low RA, then the pathology is more proximal in the celiac artery. It could be because of a celiac artery pathology, because of atherosclerotic aortic disease or some arcuate ligament syndrome. And if we see a low RA, a Pavas status pattern in the delayed follow-up imaging, the most favorable diagnosis is hepatic artery stenosis. We can confirm it with the CT angio. Here we can see a segmental narrowing with the post-stenotic dilatation. This has to be treated with intervention like hepatic artery stenting or angioplasty. And high RA is a reversible Doppler finding in the immediate postoperative period. High RA, what I mean by high RA is the resistive index more than 0.7. The end diastolic velocity determines the high RA. Usually in high RA, the end diastolic velocity is significantly reduced. We grade the high RA into four types. Type 1 and type 2, we follow with the Doppler. In type 3, where the systolic velocity also starts decreasing, we have to do a vigilant, we should be very vigilant with the frequent Doppler in this condition because it's a predisposing factor for hepatic artery thrombosis. If type 4 is present, that is an undetectable Doppler flow, then we have to proceed with the CT angio to rule out the hepatic artery thrombosis. The reason for the immediate postoperative high RA is it could be because of an old age donor, or it could be because of a steatotic liver or the increased cold ischemic perfusion time in case of DDLT, or it could be because of a diffuse arterial spasm or a graft edema or a hepatic artery buffer response. The hepatic artery buffer response is because of the portal hyperdynamic circulation, that is increased portal velocity. However, even though physiological causes are there, the pathological causes of a high RA should always be kept in mind. Transplant rejection of any phase, any stage can cause this high RA, and some hepatitis can cause high RA, and proximal to a focal hepatic artery thrombus or a hepatic artery narrowing, high RA can be seen. And also a very rare complication which is called the splenic artery steal syndrome can make this high RA throughout the hepatic artery. In addition to the splenomegaly, prominent splenic artery more than 4 mm, and increased velocity in the splenic artery with an increased portal venous velocity. So after one rare complication is hepatic artery pseudoaneurysm, where we see an yin-yang pattern in the Doppler, which is usually confirmed with the CT. So after imaging the hepatic vessels, we have to screen the entire abdomen for the presence of a free fluid or a focal collection. Bile leak is one immediate postoperative collection which can be anticipated. Usually it is very difficult to distinguish bile leak and other collections. However, any well-defined collection, a walled collection along the cut surface or close to the hilum favors the bile leak. We have to proceed with CT to perfectly quantify the bile leak, because small leaks can be ignored, whereas large leaks are prone to get infected and get organized into a bilioma. And hematoma is also common within 2 weeks after transplantation and usually occurs at the level of the anastomosis and in the perihepatic space in the lesser sac. It is usually hyperechoic at the ultrasound, so difficult to pick up unless we have a clinical indication. Unless clinical suspicion is there, it is hyper attenuating in the plain CT, and the intensity depends upon the stage of hematoma. And if there is a hematoma and there is a clinically significant drop in the hemoglobin, we proceed with the CT to find out the site of bleed and whether there is an active bleed or not, and to quantify the hematoma. And parenchyma should also be screened for any altered echogenicity and for focal lesions like or an infarct or a hematoma. Intestinal perforation is a rare complication. Usually it occurs in the pediatric in biliary atresia case of failed Kasai because of intense adhesions, and also in adults in recurrent spontaneous bacterial peritonitis patients. Biliary stricture is a late complication, is a delayed complication, and MRCP is the modality of choice to diagnose the stricture. It could be an anastomotic stricture as in this picture, or it could be a non-anastomotic stricture. Non-anastomotic strictures are usually multiple, and it involves the intrahepatic bile ducts also. So whenever we see multiple strictures involving the entire bile ducts in a post-transplant setting, we need to think of so many causes. One, mainly it is because of ischemic injury. Some rare causes are in chronic ductopenic rejection, we can get a stricture of that type. In ABO incompatibility, you can see this. And if the indication for the transplant is a primary sclerosing cholangitis, we have to keep in mind of the recurrence of primary sclerosing cholangitis. And after discharge, when the patient comes for a follow-up imaging, still the Doppler is the primary imaging modality. We have to assess the vascular patency in a similar way, and we have to look for any gross biliary dilatation. If it is present, we have to proceed with the MRCP to find out the cause, and any NASH recurrence has to be evaluated, and any chronic collection, look for any chronic collection and try to quantify the collection. Bowel hernias and diaphragmatic hernias are rare, though we have to keep it in mind. And coming to the malignancy follow-up, in case of transplant for HCC hepatoblastoma, surveillance for tumor recurrence is needed. HCC, the rate of recurrence is 15%, especially in downstage to HCC. It is a bit high for mixed tumors when it has a cholangio component. And the HCC recurrence is mode of nodal recurrence and lung metastasis when compared to that of the parenchymal intrahepatic masses. There is no set guidelines. The mean recurrence time is 13 months. So intense 2-year surveillance has to be done. It has to be done up to 5 years. Usually 6 monthly we are doing. Here it is being done with AFP as well as contrast enhanced triple phase CT with the late arterial phase with MRI screening, especially with the diffusion weighted imaging. And because of the immunosuppressed state, de novo cancers is also common in transplant setting. We need to screen for these tumors also. One such is the post-transplant lymphoproliferative disorder. And the incidence in children is high when compared to that of the adult. It is more common in the first year after the transplant. And because of intense rejection therapy, usually it presents with multiple nodal masses in the abdomen as well as in the mediastinum. Sometimes it can present with a soft tissue thickening or a soft tissue mass around the hilum, encasing the portal hilar structures, causing vascular complications and biliary complications. In this setting, there is a large soft tissue mass in the right paracolic gutter. This came in the pathology as a post-transplant. It came as a lymphoproliferative disorder. So before ending this session, a word about the APOLT. APOLT is an auxiliary partial orthotic liver transplant. Here, along with the native liver, the graft is also kept inside the abdomen. And this is done in 2 settings. One, mostly it is done in acute liver failure. In our center, it is also being done for metabolic liver disease. And the post-transplant imaging of an APOLT is similar to that of the other, similar as the Doppler, which is done routinely, except for that we have to image 2 arteries, 2 hepatic veins, and 2 portal veins. And we have to ensure that there is a preferential portal flow towards the graft when compared to that of the native liver. If the APOLT comes for a follow-up imaging, delayed imaging, it is usually done with the nuclear scan, HIDA scan. We have to assess the functional volume of the native liver as well as the graft liver. When the functional volume of the native liver approaches 30 to 50%, then they start tapering the immunosuppressant. And this is the picture which we are observing after tapering the, once the immunosuppressant is tapered, the graft liver starts to get atrophied and eventually it disappeared. So before ending this session, I just want to focus on this thing. This is the classical waveform which we need and which we are happy with, the triphasic waveform of the hepatic vein. The monophasic waveform of the portal vein with the velocity between 50 to 90 centimeter per second, and the hepatic artery, antegrade pulsatile hepatic artery with the resistance between 0.5 to 0.7. In hepatic vein, the phasicity is important. Whenever there is a loss of phasicity and we get a dampened monophasic flow, then it is a worrisome situation. And in the portal vein, the flow, that is the velocity, is very important. If there is high velocity or if there is a low velocity, then we have to intervene. In hepatic artery, whenever there is no flow in the hepatic artery or a low RI in the intrahepatic segment, we need to evaluate. High RI is normally a reversible Doppler finding. We can wait. We can follow up for type 1 and type 2 high RI. For type 3 and type 4, we have to proceed with the further investigations. Thank you.
Thank you, Dr. Komala. It was a splendid exposition of Doppler and of the intra-op and post-op imaging, and a very, very wide topic. But if you ask me, the single highlight of the whole talk is, the extent of transplant surgical knowledge which both radiologists possess. I think it's so important to work together and to have an open channel of communication between the surgeon and the radiologist, so that we get the information what is needed and they also know what to look for exactly. We have Prof in the audience. Prof.
Hi. Ashwin, I think both of them gave very good talks actually. There isn't much for me to add. I'm always interested in radiology. I think pathology and radiology are things that I've always been interested in. And I just want to, I think we have such fantastic radiologists. We are so spoiled really in having one of the best pictures that you can imagine in terms of I'm very fond of CTs much more than MRI because I'm not so good at reading MRIs. The timing is what I see. Whenever we get images from outside, when patients come to see us and we look at the images, it's actually not the same as the images we produce. And really, I want to ask Priya, isn't it so important? And why is it that many people don't get the timing wrong? Is it a lack of understanding about the timing, or why is it that many external, standalone CT scan units, why can't they produce the same level? I mean, the general perception is the machines are not very good. I don't believe it's the machines. I think even the basic 36 slice CTs can produce as good an imaging. It's all about timing, isn't it?
Yes, sir. Yes, Prof. Basically, I think they are used to doing this biphasic scan because they do like a late arterial and then a very late venous. So it kind of, because that's, unless we are specifically looking for a liver pathology, I think most outside scan centers are used to doing that kind of thing. So anything that may help in a GI kind of setup, if we are looking at something in the bowel or, but I think when it comes to the liver, it is very important that, and we train our radiographers first thing as to get into this late arterial phase and the proper venous phase, because I think it's awareness more than anything else, because we see here, and if we do miss the late arterial, we see what happens. So, suppose sometimes the pump doesn't work or something, if there is something, it immediately spoils the scan. So we are much more aware of lesion characterization at our center. And I think the fact that we see so many of them, but I think it's a lack of awareness which leads to
Thank you. And the other thing I want to impress upon all surgeons is I think they should all get used to looking at scans rather than looking at reports. Actually, I have to say that I don't rely hugely on the reports, but I think it is important that everybody reads it. Can I say something? I mean, you talked about HCC and washout, and I think I would like to explain as a surgeon to the surgeon, and yes, correct me if I'm wrong, Priya. You talked about early arterial phase, and HCC is bright and then it washes out, and I just want to explain to the surgeons what actually this means and why it is the way it is, from my understanding. Um, the first point to remember is HCC is a tumor which is highly vascular. It's vascular in the sense it's highly arterialized. And the second point to remember is that HCC does not have portal venous supply. So in the arterial phase, it's very bright because it's highly vascular, highly arterialized, and more arterialized than the rest of the liver, and therefore it is bright. And in the portal phase, what happens? The artery washes off. The rest of the liver actually becomes very bright because it's got portal supply. And in relation to the rest of the liver, which becomes bright, the lesion becomes really hypodense. So it's really, I mean, there is an element of washout from the arterial phase, but there is a washout of the rest of the liver from the arterial phase as well. But it's the portal venous phase which makes the liver bright and actually the tumor very hypodense. I just want people to think about it that way rather than use the terminology just washout. In fact, it's more than washout. It's a relative density, relative vascularity of the tumor with respect to the rest of the liver, which makes the appearance of what we call a washout. Isn't that right, Priya?
Yeah, yes, Prof. Yeah, it's a relative washout. Yeah.
Yeah. It's not just the arterial flow which comes in and then it washes it out, and then it's because the rest of the liver becomes bright from the portal phase that it looks really washed out.
Yeah, yeah.
Okay.
Actually, if you put the values and see, it is actually very confusing. We've tried doing this. Remember, Komala, when we try to characterize and we start putting values in the plane and the thing, it is a relative phenomena, as you say, because it takes all the arterial supply. It's a unique tumor that way. I think it's a tumor characteristics. That's what's reflected on the CT.
Yeah. Yeah, I just wanted people to think about it that way, because when I thought about it, that I found that really interesting for me to think about it that way. That's why I said that. I really don't have much more to add, actually. Is there any questions from the audience we can take?
I just had a few questions to run by both Dr. Priya and Dr. Komala. One is, and as you showed, Dr. Priya, MR as a single modality can take care of everything for the recipient to the donor. But as surgeons, like what Prof said, we are not inherently comfortable with an MR. Do you think in the future MR will replace CT?
I think one thing, Ashwin, is MR, especially for the recipient, there are two things that affects its, if there is a large volume ascites, or if the liver is quite cirrhotic, that the iron load is high, then both of these cause artifacts. So especially when it comes to this iron related ferromagnetic artifacts, there's nothing we can do. All we will see is black arcs forming. So in those cases, we actually cancel the scan. So I don't see this replacing MR replacing CT for recipients. I still think CT is a better modality in terms of the resolution and everything. But maybe for donors, I think if we can get thinner images, you know, to the quality that we are getting in CT, maybe and I think quite a few centers in Bombay actually use contrast MR itself because they're able to do the fat estimation and everything. Again, MR elastography is something that is we were doing it before as well, which is very good to pick up. It gives a map of the, you know, the elasticity of the liver. You know, you can quantify the extent of fibrosis. That may be something. So for the recipient, I think it is still CT and MR for problem solving. Whereas for the donor, maybe MR may, you know, with time. Because some centers do very good angiograms. Again, it all depends on the patient cooperation also. For MR, the patient really needs to cooperate to, you know, lie in the scanner and, you know, follow the breathing and all that. So that also will vary. There are some donors we know who refuse to go and lie in the scanner, and we say that's all right. You know, they can do an intraoptical angiogram for the MRCP, donor MRCP. So I think CT is still here for a while.
Your views, Dr. Komala, do you agree with that, or do you have anything to add to that? You're muted, Dr. Komala.
So I do agree with this. For recipient, it's MRI is not much accepted thing, whereas for donors, it could replace CT.
That actually leads to the next question. Now we do donor CT volumetry. Now, do you have any volume estimation with regards to the blood or the vessels which are there? Do you reduce a particular percentage of the volume, or do you just provide the exact volume? Because with regards to different types of grafts, you can have different errors with regards to weight.
No, there will be a difference always, because when you get the liver out, I think it's squeezed out. So the blood volume that we, especially when we hydrate the donors very well. Yeah. So there is always at least a 10 to 15% difference. In fact, there was a time when we used to actually map out the portal vein and the hepatic veins, and the portal vein would be around 90 to 100 cc, and the blood in the portal vein and the hepatic veins would also be around 100 cc. So around 200 cc, we would subtract from the whole liver volume. So on an average, 10% subtraction can be definitely estimated. It will not be the same as what we give, because that is with the full blood in the liver.
Dr. Komalavalli, we sometimes see two peaks in the hepatic artery Doppler, which Prof usually says is quite normal. It settles down. I mean, I just wanted to know out of interest. I mean, it's a very technical question. I just wanted to know why that happens, and I would also like to know why Prof thinks that it's a normal thing.
No, actually, it is quite normal to have a two peak in hepatic artery sometime. This is because of and that the velocity, because of high velocity, we can have two peaks. In that scenario, we have to take up the largest peak as the peak systolic velocity, and we have to calculate the resistive index.
Prof, you have anything to add to that?
No, nothing really. I don't think. Yeah, it's always worrying to have two peaks. I sometimes worry if there is a little flap or something which hinders with the first peak, and then the flap opens in the anastomosis and you get the second peak. That's always been my worry about two peaks. Do you understand? If there is a very small flap at the site of the anastomosis, you might find that before the flap opens up, the peak may be a bit smaller and then it opens up further. But I don't know. But I don't think it's ever caused hepatic artery thrombosis in those patients.
Any other questions from the audience? Both the talks have been so comprehensive that you know, there's actually little for me to ask. Whatever questions I had, you've answered it during the course of your talks. We have a question in the chat window. Post-operative stricture diagnosis, especially in the early post-op, is there any specific guideline? Dr. Komala, would you like to take that? When do you suspect a biliary stricture with regards to imaging?
Early post-operative period, biliary stricture is a bit rare complication. I think I have not seen that, but in delayed imaging, delayed period, that is more than down more than 4 to 6 months, we can expect biliary stricture. And whenever there is an elevated, when the clinical picture is more in favor of obstruction, we have to get along with the imaging. And when there is a gross biliary dilatation, we'll proceed with MRI to find out the level of stricture and the type of the stricture.
You want to add, Dr. Ilango? I think you have a mic on.
Ashwin, no. The only thing is that for portal flow, we are using a cutoff limit, the lower cutoff limit of 20 to 21 centimeters per second. I was a little surprised to see 15. We are really scared of low flows at less than 20. Any comment on that from the radiologists?
Dr. Komalavalli.
Actually, there is no set cutoff for that. It is what we in our center practice is less than 15.
Where did you get
I think, can I answer that?
Yeah, sir.
Yeah, I agree with you, Ilango. I think less than 20, in adults, less than 20, I would worry about. In pediatrics, maybe 15 is okay. But if the velocity is low, I think you do need to worry about steel actually. Because it's very rare for you to see flows of 20 in adults. I mean, we are talking about velocities of 50 and 60 in adults normally. So it always worries me if the velocity is less than 20. There is another thing that you need to worry about. If the velocity is low, then you have to measure the pressure. The pressure is high and the velocity is low. You have to think of an outflow problem, actually. If the pressure is low and the velocity is low, you have to think of steel. Below 20, I would worry in adults.
There is one more question I have. Our standard disease donor transplantation KVK was to me, side to side KVK was to me, because I find it much more easier to teach. We have always observed biphasic flow in that. The grafts have actually done well. We have not had any issues. This is always a concern that we don't get the good triphasic flow like we see in the piggyback, the standard piggyback. I would like Prof's comment on that and the radiologist comment as well.
I'm not surprised actually that it's not triphasic because the side-to-side anastomosis, even though the pressures may be low, it's not actually a straight communication between the right atrium and the right hepatic vein. So the right hepatic vein orifice is higher. It drains into the cava and then it has to flow a little bit below and then it goes up. So I don't think it's actually that big a surprise that it's not triphasic, but it's not harmful. Actually, even a biphasic flow is not harmful to the graft as long as the pressure is not high in the hepatic vein, as long as there is no gradient between the IVC and the right atrium. Or the right hepatic vein and huge gradient. I mean, you will have some gradient, maybe, if it is less than 5, I don't think it will be a huge problem. And I wouldn't expect it to have a triphasic. If you have a triphasic, that's good. Maybe you've made the incision very high up. I don't know how close to the hepatic vein orifices you make the incision. Is there a gap of at least 1 centimeter?
We want to see the vein orifices, so we go quite high up.
Yeah, then it's okay. That's all right. Because it's not quite straight, is it? If you draw a line across from the right hepatic vein in a caval replacement, the right hepatic vein will straight go into the right atrium if you draw a line. Whereas if you draw a line of continuity, you go up and then you go slightly down and then you go up in your side-to-side anastomosis in terms of the flow. So it's not necessary for it to be. It won't be triphasic.
Thank you, Prof.
Yeah.
Any other questions from the audience? Patta sir. Okay, and if you have no further questions, then it's been an excellent session on diagnostic radiology in liver transplantation. And like what I said, if there was a single take-home message which I can see here is the fact that the surgeons and the radiologists need to work together, have an open channel of communication. And it's quite stunning to see the extent of surgical knowledge which both our radiologists have. It's actually a little scary to say.
We've learned it all from you, Ashwin.
But did you know that both of them are married to transplant surgeons? That's all they're hearing at home. I wonder if both surgeons are as good in radiology as as the wives good in surgery. I think they are. Actually, I think they are. I shouldn't leave it like a question. Let me complete it by saying both the husbands are very good with radiology as the wives are good with surgery.
And thank you so much, Dr. Sripriya and Dr. Komala, for your time and the excellent talks. And Prof, thank you once again for joining in. With this, we'll close this session and meet maybe next week for another topic. Thank you so much, Veda.